Now, there are many types of telehealth in operation at the moment, usually small studies, and we need to coordinate and work internationally on this. But telehealth in general, whatever it may be, video conferencing, and mostly in oncology, it's monitoring the side effects and symptoms of the cancer patient, especially following chemotherapy. We must be cognizant that it must fit into the culture of the patient and adapt. We can adapt some techniques and some devices we've got for the individual patient, but it also must also go into the workflow of the healthcare professional. So it shouldn't be an add-on because all healthcare professionals say, oh, not another thing to do, but it should be integrated into their usual work. So these are two things that should happen with telehealth in general. So an example of what I'm speaking about at SIOG is a device specially adapted for the older oncology patient, and that was finding out how the patient felt at home. These were patients who were on chemotherapy and finding out their signs and symptoms, but not only that, but really their experiences and how they actually felt. So that included quality of life and did they feel distressed at all. And that device was a 4-button simple home-based gadget in their house that linked into our oncology unit to a server which linked into our oncology unit at University Hospital Coventry in Warwickshire. We were trying to encourage self-management in the older cancer patient as well, and clearly that may help the organisations like acute hospitals, you know, from patients coming to and from hospital all the time. So that may decrease the visits for the patients, and we're able to do things such as remote clinics and remote hospital visits through the internet as well. But certainly encouraging self-management, so it's called supported self-management at home and in end-of-life care as well. We tried to incorporate this study, which was the device study. It was called the Health Buddy, and it was developed by Bosch Healthcare. And we tried to incorporate that into our systems that we had in the hospital. So this was not, sadly, in the community, but the patient was at home. But it was run by the hospital services that we already had, and indeed the acute oncology team, and that was a nurse-led team, looked after all the responses they got, because the patient was able to say whether you know, it was a red alert, so whether it needed us to do something about it within you know, an hour or within 15 minutes in some cases, or whether it was an amber alert, it could wait for a few hours, or whether it was just a normal alert that they needed some reassurance about. So the red alerts all went through this acute oncology team, and we would classify them as possibly life-threatening. So we were trying to incorporate it within the teams, but interestingly what we found is that mostly the patients were pushing the button on their device for being very distressed. So most of the results that we got back and the red alerts that we got back were due to distress and fatigue and things that the acute oncology team were not really experienced in. So what we did about this was we trained up a support worker, so a nurse assistant, in order to take the alerts, the distress alerts. So she was trained in counselling cancer patients and took that job on, and that decreased the work for the acute oncology team, who could concentrate on the more physical side effects. But clearly to the patient, the distress and the fatigue and everything was very important to them, and we had to deal with that. We found when we phoned the patient back, because The deal was that we phoned the patient back within half an hour if it was a red alert. It was often social problems that were the cause of their distress. So we had to find out the cause. It could be a physical problem like dreadful diarrhea or whatever with their drug regime, but as long as we found out the cause of their distress, then they were triaged appropriately, really. Just as I started, just to say that we have to adapt for the geriatric oncology patient. The mean age of our small study with the device in 73 patients was 62, so that was a young population, but age was, when the statistician did the analysis, age was not a factor in any of the results, so age did not affect the patient using the device or affect the number of alerts or the types of alerts.